cancers. We would like to welcome the resource team from CMC Vellore, Dr. Patricia, Professor, Department of Radiation Oncology, Mrs. Revati, Senior Staff Nurse from Pediatric Oncology Ward, and the moderator for this webinar, Mrs. Menaka Raguraman, again Professor and Nurse Manager from the same unit. A special welcome to all the students who have joined in groups from various schools and colleges of nursing across the country. We would like to welcome all the senior members who have joined us today. Thank you for your support. We have a few announcements before I hand over to the moderator. Please type in your email ID in the chat box. Please mention your institution name and the number of students attending in the chat box. We will be posting a feedback form at the end, towards the end of the webinar. Kindly fill the form so that we can get real feedback about this webinar and we can improve with each webinar. Please be conscious of your mics and videos. Please do not unmute unnecessarily during the webinar. Please type your questions in the chat box. We will give you opportunity to ask questions directly also at the end of the webinar. Now, I hand over this webinar moderation to Mrs. Menaka Raguraman, Nurse Manager and Professor in the Pediatric Oncology Unit of CMC Vellore. Over to you, Mrs. Menaka.
Thank you, Shimi, for this opportunity. This is the third webinar series that we are meeting. And in the previous sessions, we discussed about chemotherapy and psychological supports for the child and family and those topics. Today, we are going to discuss about radiation therapy and what is the role of nurses in managing the side effects. And before that, we will have a comprehensive overview of pediatric radiation therapy techniques by Dr. Patricia. Dr. Patricia is the professor in pediatric radiation oncology department, and I really thank her for accepting to be the resource person in spite of her busy schedule. I welcome Dr. Patricia to present her session. Thank you.
Thank you so much. Are you able to see the screen, the slides? Am I audible?
We are able to see.
Yes, you're audible and the screen is also visible.
Okay. So thank you for inviting me and giving me this opportunity. It's really nice to meet you all in this platform from all over the country. So this is what I would like to present today. What are the pediatric tumors, the common ones and the prognosis? What is radiation? What is the benefit of radiation in these tumors? What are the techniques? What could be the probable toxicity, and what can be your role in these patients? So coming to the common cancers in children, the most common are the leukemias. Then comes the brain tumors, brain and spinal cord, lymphomas, and other solid tumors like Wilms tumor, neuroblastomas, and sarcomas, mainly rhabdomyosarcomas. So when we look at the prognosis, this is the paper that tells us comparing the survival somewhere 1970s in each of the cancers to the current, at least in the last decade. In every cancer, if you see, the survival was ranging somewhere 40 to maybe 60%, except Hodgkin's a little more. But whereas in the last decade, it has all improved to 75, 80 to almost 95%. So that is the progress that has happened in the treatment of pediatric tumors in the last few decades. And since all of them are having very good prognosis, it's very important to know what happens to them when they survive and what are the challenges they face and how we can help them. So this is just an example to tell you leukemias, how from 20% in 70s has become 60% surviving now, and lymphoma 70 to 90%. So overall, 85% of the children with cancer survive into adulthood. So that is real good news compared to what happens in cancers in adults. Children survive better, they are cured better out of their cancers. So that is something to remember. So they are all going to live into adulthood. So though they are cured, are they living with good quality of life is another question that we need to keep in mind when we treat these children. So coming to what is radiation? Radiation is nothing but it's energy that is transmitted in the form of either waves or particles in the space. And radiation is used not only in medicine, it's used in industry, agriculture, research. So this is the electromagnetic spectrum of radiation. They can be divided into ionizing and non-ionizing radiation. Non-ionizing radiation is the visible part of radiation. That's the infrared, microwaves, radio frequency. Whereas the ionizing ones are the invisible radiation, alpha, beta, gamma, and X-rays. And they're called ionizing because there is removal of orbital electrons from those atoms, and they are ionized. So what do? They act on the DNA. They cause damage to the DNA. And whenever there is both the strands of DNA break, it results in either cell killing or carcinogens or mutation. So this causes tumor cell damage more because the cancer cells are fast dividing. So there is a lot more DNA damage to the cancer cells compared to the normal cells. So when we look at what is the benefit of radiation in these tumors, I'll take few examples of common tumors. In leukemias, whenever there is CNS involvement, chemotherapy drugs do not enter the blood-brain barrier much. So CNS involvement has to be treated the other way. One is intrathecal chemotherapy, that is do LP and put in the chemo drugs into the CSF space. And the other one is to give radiation. So radiation has a big role when CNS is involved in leukemias. The other region is testicular relapse. Testicles also is another sanctuary site in leukemias, and radiation is used in treating this region. It's also used as a part of conditioning regimen in bone marrow transplant. Prior to transplant, either to ablate the marrow or to suppress the immunity to prevent rejection of the transplant. Radiation is used as a whole body radiation or whole body total marrow lymphoid radiation as a part of conditioning regimen in transplants. Of course, radiation is always used in palliation for helping with reduction in pain or any other symptoms because of disease. Brain tumors, there are a few examples. It's used as a curative option in intracranial germ cell tumor along with chemotherapy. Surgery is not offered at all for germ cell tumors. Surgery not necessary except for some diversion procedure or biopsies. And brainstem glioma is another area where surgery inaccessible area. So it is treated with radiation. And as adjuvant treatment, of course, in gliomas, ependymomas, medulloblastomas. In lymphomas, whenever there is residual after chemotherapy or PET positive in the interim PET, in non-Hodgkin's, in adjuvant disease or bulky disease, adjuvant setting or bulky disease. Of course, palliation almost in all settings. So this is another paper just to give you how beneficial is radiation. This is a vaginal rhabdomyosarcoma patients where radiation, when avoided, there was increased local recurrence. So there's a difference of almost 26% versus 43%. So when you give radiation, there was reduction almost half of it. So it shows that radiation is needed to reduce the local recurrence in these patients. So this is another example where infants less than 1 year old with rhabdomyosarcoma, when they were not given radiation, there was almost 54% local recurrence. When they were given radiation, 28% only. And MSKCC reported their 2-year local control rate of almost 84% with radiation in less than 3-year children with rhabdomyosarcoma. So these are some of the examples to tell us that radiation is beneficial in these patients. In Wilms tumor, here's another report of 175 patients from PSYOP showing local failure is just 9% with RT, whereas it goes more than 15% when you don't give radiation. So radiation is used almost 1/3 of children with cancer as part of their treatment for curative purpose and palliation in many more, and most commonly used in sarcomas and brainstem gliomas, of course, leukemias as we discussed. So coming to what are the techniques and what is radiation, how is it given? So radiation treatment is usually not a single day. It can vary from 2 to 6 weeks, depending on the disease and the site and the dose. So we need to make sure that a patient is lying in the same position every day. So immobilization of the patient becomes important. So we start with immobilizing the patient with immobilization devices. And after that, CT scan is done along with that immobilization using what is called CT simulator machine. So that is a machine with a flat couch, little modified to do a CT scan. Then what we do is so then after the CT scan is done, we mark out the regions to be treated, all the target volumes and regions that need to be avoided, the organs at risk on the CT scan. And then radiation treatment is designed, the beams, how should it go and how much and all that. So it's optimized. And when we are happy with the treatment that is planned, we do a quality check whether what we have planned is able to be executed or not. For high-tech treatments, we do patient-specific checks also. After that, the position check is done for the patient and then treatment is started. So these are the various immobilization devices that we use. For children, we also need, for very small children, we need devices to keep them not fall from couch. So these are thermoplastic masks used for brain, head and neck region mainly. It can be used for thorax, abdomen, extremities also. These are vacuum bags that is used to immobilize thorax, abdomen usually. So various techniques that we have. Radiation broadly can be divided as teletherapy or brachytherapy. Teletherapy means from far and brachy means near. So from outside, this is the machine for teletherapy, and this is the small machine for brachytherapy where the tubes are connected to the catheters in and around the tumor, and radiation goes inside the tube. So this is internal radiation and this is external radiation. And each of them have different techniques again. Brachytherapy, it can be low dose rate seed implants, it can be high dose rate. So this machine is a high dose rate machine. Similarly, teletherapy, you can have 3D CRT, or it's called three-dimensional conformal radiation, IMRT, intensity modulated radiation, VMAT, that is volumetric modulated radiation, image guided stereotactic radiation. So there's another picture showing the teletherapy machine where we can do the high-tech treatments. So this machine has a CT scan attached to it. This CT scan helps us to verify the position of the patient before the treatment. So these are some of the various machines. This is the CT simulator. So here is where we do the CT scan that is needed for the radiation. This is slightly different from the CT machine that we use in radiology. The bore is bigger because it needs to accommodate the immobilization device also. And the couch is flat. And there are measurements and fixing devices on the couch that helps us to fix the immobilization device. So this is the cobalt machine. Cobalt is a natural radioactive source. So this cobalt machine is not getting popular, may become totally obsolete in the coming decades. Problem is, even in its off position, there is some radiation leakage. So radiation protection of personnel who's working becomes a challenge. Then there's the linear accelerator where X-rays are produced. X-rays of different energies can be produced. Usually we use 6 MV energy and 10 MV energy, but there are 15 MV energy also that can be used. This is the brachytherapy internal radiation machine. This is gamma knife. Gamma knife is also a machine where cobalt source is used to treat the intracranial lesions only. Very small lesions, even up to 0.3 millimeter lesions can be treated using gamma knife. This is cyber knife. Cyber knife is same linear accelerator, but it is mounted on a robotic arm so that the radiation beam can be directed in many directions. Here we have some limitation in the linear accelerator. Radiation cannot be given in some directions, whereas in cyber knife, because of the robotic arm, you can give radiation in many more directions. Both the couch and the linear accelerator is mounted on a robotic arm. This is a proton machine. Proton therapy is a particle therapy, and this is also coming in a big way. We already have 2 centers in India. Proton is useful in that the dose to the normal structures is much less compared to the other photon therapies. So how did radiation techniques evolve? So this is the old conventional method that we used to use. I'm taking an example of a brain patient. This is the patient lateral X-ray of the patient where the area is marked where radiation needs to be given. So this is the thermoplastic mask. So earlier what we used to do is we used to mark on the either side of the patient this way, area to be marked, and we used to give one beam from this side, the other beam from this side, and only 2 beams were possible. And today's era, where we have CT scan and technology to draw all these things, if we simulated the same thing on this image, this is how it would look. If you notice, we have missed out, this red is the area that needs to be treated, and we have missed out a part of it. And there are a lot more normal brain that has been included. The green border is the area that needed to be treated. This is the optic apparatus that needed to be avoided. This is the brainstem that needed to be avoided. So this is how we would have treated in the olden era. And if you see the radiation dose that that patient was getting, if you see this entire normal brain area also was getting almost the full dose. So if this yellow line is a 95%, and it was getting the full dose, including the tumor, the normal brain also was getting the full dose, and there was more than 100% dose getting deposited in the normal brain. In the 3D era, we have technology that has improved so much and helped us. We have what is called CT-MR fusion. In the brain, it's difficult to see a tumor on the CT. If you notice, this is the CT part and this MRI part. Tumor is seen better on the MRI. So if you want to mark out accurately, MRI is necessary. But for planning radiation and seeing how much radiation is deposited where, the CT scan is useful. So we need a CT to measure radiation. So this fusion software helps us to mark out the tumor on the MRI, and that is seen on the CT scan, and that helps us to plan on the CT scan. And we have what is called shaping device, where the opening on the machine, linear accelerator, is divided into smaller leaves so that can be moved independently and it can shape. So when we saw the previous conventional, there was normal brain that was getting included. That can be shielded in this era. So I said we could give only two beams from either lateral side, but in the 3D era, we are able to give any other direction. Now here there is another beam that has been planned from the anterior direction, which is difficult when we use the 2D era. So when we did customized plan in the 3D era, if you notice, the 95% line has come exactly to the tumor. So the normal brain is getting very, very less dose, less than 80% dose. So this is a coronal view. And the maximum dose is just 101 compared to more than 102 sitting in the normal brain in the conventional era. So these are the advantages. So it decreases the amount of normal brain irradiated, dose to the normal brain reduces, and hence reduces the complications, improves the quality of life. So what are the types of conformal radiation? I was telling you about a three-dimensional conformal radiation, where the beam could be shaped. There is also what is called IMRT, that is intensity modulation, where the software of the computer can develop a radiation technique where we can change the intensity to each voxel of the field. So intensity is varying across the field. So this is the way it is done. The leaves keep moving, and the speed and the shape it takes and the amount it is open is optimized, and hence we are able to get similar to this. Wherever we want lesser dose, that is achieved. Wherever we want more dose, that can be achieved. So this is called IMRT, or intensity modulated radiation therapy. So this is stereotactic radiation therapy. So this is another software where we can use stereotaxy. Stereotaxy means finding a point in the space. So using this, we are able to direct beams in many other non-coplanar directions, which is not possible when we don't use stereotactic system. So here many other direction of beams are possible as is shown here. So this is just an example to compare different techniques. Here I have shown a patient who needed craniospinal RT. Both brain and spinal cord needs radiation, like in medulloblastoma probably. And if you look at different techniques, 3D, MRT, VMAT, tomo, and proton therapy. So 3D, if you see, the red is more than 100%. Unnecessary more than 100% is deposited in the back of the patient, and almost the entire body is getting the radiation, though the needed is only in this yellow region, brain and the spinal cord. Whereas in IMRT, the low dose is reduced, and in proton therapy, the entire body gets zero dose. So the treatment where it needs to be given, only that region is getting the radiation. There's some disturbance. So coming to probable toxicity. So the effect of radiation, it can be divided into two. One is deterministic effect. So that is due to the cell killing. And here the effect is definite when the doses cross the threshold level. So for example, cataract will develop if the lens is getting a threshold, more than threshold dose. Sterility will happen if the gonads get more than the threshold dose. So there's another biological effect of radiation called stochastic effect. And this is not a definite effect. It's a probabilistic effect. It's a random process. And here there is no threshold dose, but the chances of occurrence is proportional to the dose. And usually it cannot be prevented, and it can happen even when there is low dose. So somatic effect is effect which is definite when the dose crosses the threshold level, and the hereditary effects is effect that has happened in the cell exposed person in the germ cell, and this damage is passed on to the progeny. In our body, we have different tissues, and each tissue is susceptible in a different way to radiation. So these are highly susceptible tissues like lymphoid organs, bone marrow, testes, ovaries, intestines, skin. These are intermediate radiosensitive tissues like stomach, growing cartilage, kidneys, bones, liver. And these are quite relatively radio-resistant tissues, mature bones, adrenal gland, pituitary, brain, spinal cord. So coming to radiation side effects, they can be divided into acute, subacute, and chronic side effects. Acute is up to 6 weeks of completion of RT. For example, if skin is involved, it can be dermatitis, mucositis, it can be diarrhea, fatigue. And subacute is from 6 weeks to 6 months. Usually acute and subacute side effects are reversible. chronic side effects are irreversible, which can occur after 6 months. So this is an example of acute dermatitis. There is grading from grade 1 to 4. We usually do not allow it to go to grade 3 or 4. We interrupt radiation if it is going to grade 3 or 4 dermatitis. This is an example of mucositis, again grade 1 to grade 4. Grade 4 is when there is secondary infection, necrosis, or bleeding in the mucosa. So long-term side effects that are common in children is growth abnormalities, which is not seen in adults because they're all growing bones, not yet fused. So growth abnormalities is one of the side effect which we need to keep in mind when we treat children with radiation. And other long-term side effects depend on the site. Like if it is pituitary region, it can be hypopituitarism. If it is hippocampal region, cognitive decline. And second malignancy is one thing that can happen either with chemo or radiation. And when both are given, the chances are much higher. This is another example of our patient who, this boy is actually 21-year-old boy who is having a short stature because he was treated with craniospinal radiation in childhood. So his growth was affected and he is remaining short even in adulthood. So what do we do to reduce dose to critical structures? We use better techniques. We try to reduce the dose to the bones and reduce dose to the hippocampus to prevent long-term intellectual issues. We reduce doses to the gonads to prevent the fertility issues in long term. So there are certain doses that we know as threshold doses or limiting doses for each tissue, and they're usually lesser than what is in adults. And when we treat patients, we make sure that we keep below this. Sometimes, if we cannot, we need to consent that we are crossing the tolerance limit. Radiation-induced second malignancy is something very people are really scared of, but I just want to tell you that it's quite rare. It's only 3.5% chance in 25 years. And bone and soft tissue sarcoma is the most common. Chemo also has second malignancy chances as side effect, and chemo given along with radiation increases its risk. And there is also underlying germline mutation itself that can be the reason, because we see leukemias developing in certain patients, and because they already have an underlying germline mutation. So the aim is to maximize the cure, but keep in mind and minimize the toxicity also. So what is your role? So these children are so scared looking at the big machines. So it's important to make them feel comfortable. In many places, there is a play specialist available to take care of the child, make sure the child is comfortable, child is playing when the child is waiting for anything, child is told everything what is going to happen. And there's a video recording that is shown to prepare the child how the machine would look and how the immobilization will be made. And child is taken to the place beforehand, made the child comfortable. And doing all this helps us to reduce the need for anesthesia for these children. As I said, these children have to lie in same position, should not be moving. So children below 3 to 5 years, it's difficult for that. So we need anesthesia for those children. So make the environment child friendly. This is one of the way we do, or we can make child friendly. For example, the mask that we use to immobilize, we can paint to cartoon characters or whatever they are interested in. So these are some of the examples where people have done. As I said, orient the child to the treatment environment. Use some distraction aids. So this is in Stanford University, where they project a video onto the ceiling during the treatment. So child watches a favorite video while the treatment is on. This is again a mask with the He-Man picture. Then about follow-up, both the children and the family, children, especially the adolescents. They are so worried about the recurrence. They are worried about the cosmesis, bad cosmesis if they've had, the way they have to adjust to the society, sexuality issues, changes in social support. When they have to get employed, they get discriminated, financial issues, quality of life issues. All these needs to be dealt. And this can be done only when we increase the knowledge of late effects of cancer therapy to them and help them to recognize early when they get it and treat early. And for detecting second cancers, screening methods, make them aware, detect early, anticipatory guidance, and modifiable risk factors, get them into a healthy lifestyle so that chances of getting second malignancy reduces for them. Yeah, this is all I have to say. Thank you.
Mrs. Menaka.
Thank you, Dr. Patricia, for a wonderful session. How it was and how it is now, and what are the advancements in the technology which brings out a very good outcome for the children. So it was very useful. There was one attendee, Jamuna Rani, is asking, tell about CT simulator. You explained when the slide came, but is it possible for you to just say
Yes,
once
yes,
more?
yeah. Yeah, so
Is
CT
Jamuna Rani
simulator.
there? She only asked to tell about CT simulator.
Yeah, so basically CT simulator is nothing but the CT machine, which is modified a bit for us to do the radiation planning. So modifications are, it has a bigger bore compared to the radiology CT machine, so that the immobilization device also can go in along with the patient while taking the CT scans. And the couch is flat so that it doesn't disturb our radiation beams. And the position is made same every day. So those are the main two differences. The other one is the couch has some marks and fixations which helps us to place the patient in the same position every day. So that is planned. It is similar to the treatment machine. The couch is similar to the treatment machine on the CT simulator. So that helps us to plan the position so that that can be reproduced every day. Patient has to be in the same position because we design beams and those beams have to go to the same place every day, right? So if there is a change in position, then what we plan will be delivered somewhere else. So we will miss the area to be treated. So positioning becomes important. So somebody is asking me about cobalt 60. Yeah, so cobalt 60 is a natural radioactive source. So we have a radiation machine which has cobalt 60, which emits gamma rays. And cobalt 60, because it's natural radioactive source, problem is radiation protection. Even in the off position, there is some radiation that is there in the surrounding. So personal to work, we cannot make a person be there more than 8 hours, and so many other restrictions, and public cannot go, and pregnant ladies cannot work. So all these restrictions are there. And cobalt penetration is lesser compared to the X-rays. So it is not useful for bulky patients and in the pelvis where deeper penetration is necessary. So that is about the cobalt. So that is why I said it is almost going to be not there in the future. Right now it is there because it is cheaper, maintenance is cheaper, treatment charges are cheaper. We still use it for palliation. So cobalt is there. There is another gamma knife which uses cobalt sources for brain tumors. Gamma knife has many sources, like 200 small cobalt sources. And so we are able to treat very, very small lesions, 0.3 mm, like trigeminal neuralgia, epilepsy disorders. So those things can be treated using gamma knife. So that is another cobalt using machine, but that is nicely shielded and useful because we can use very, very small areas very accurately. So, yeah, that's about the cobalt.
Thank you, Dr. Patricia, for the enlightening session. If there are any more questions, we will answer at the end. We have another speaker, Ms. Revati, Senior Staff Nurse in the Pediatric Oncology Ward, waiting to present about the management of side effects seen in children undergoing radiation therapy. So I welcome Revati to take over the session.
Good evening, ma'am. Good evening, everyone. Thank you for this great opportunity. And myself, Revati. So I'm going to present about managing the side effects of radiation therapy. Radiation therapy is a local treatment modality for cancer using ionizing radiation delivered by a linear particle accelerator. It's also used as a neoadjuvant or adjuvant therapy. Neoadjuvant therapy is treatment given before the initial treatment starting, mainly to reduce the tumor size after the main treatment. So adjuvant therapy means after adjuvant therapy is like to prevent to reduce the risk of a tumor recurrence after the initial treatment. So how RT works? It damages the RT damages the DNA of cancerous tissue, leading to cellular death. Thereby, it controls the cell growth. Next slide, please. These are some of the commonly treating conditions RT in children. These topics ma'am already covered in the previous session, so I'm not going to detail. This topic also ma'am covered. That let's say detail about a nurse's care. Nursing care is as nurses we are doing providing care very importantly. Some of the care we were doing as nurses, we must be knowledgeable and skillful in identifying side effects and able to, and we must be knowledgeable in identifying the side effects and managements also. Some of the care we are doing independently, for example doing dressing, giving health education, that is an all independent role. Some of the roles it is interdependent roles. For example, administering medication, we need a doctor's roles. If we are referring to the physiotherapy means we need a physiotherapist. So some of the interdependent roles also we were doing. So it is a holistic approach, like a physical, emotional, psychosocial, and spiritual aspect. Next slide, ma'am. So coming to the emotional and psychosocial support, first we have to provide a reassurance and comfort to the family members and the child. Use age appropriate language to explain the procedure and possible side effects. We have to explain them in a simple language according to their knowledge level. Involve parents in care and provide them with information to manage their child needs at home. Most of the time, RT we are not admitting, it is a OP treatment. Unless if the child needs anesthetic, general anesthesia, so in that case we will admit. So during OP treatment, if the child develops any side effects, means the parents must know how to take care of those side effects in the home setup. Then offer resources such as support groups or counseling. As nurses, we can also counsel the parents and the children by spend some time. If they are very much worried, means we can introduce them professional counselors or any cancer survivors, really to relieve their pain and anxiety level. Use toys, picture, books, music, videos, or games to help the child cope with the procedures and treatment. We can ask them, children, their favorite music or some of the songs. So we can play during the hearty time to relieve their anxiety level. Then preparation through education for RT. Orient the child and the family members. Hope you all seeing this first two pictures. This therapist is orienting the child about the RT room setup, how RT machine is working. With the model she is showing to the child. So the child is orienting what is happening inside the room. So they will cope better in the actual scenario if we orient them well. So that we have to orient the purposes of the RT, the process means how many sittings the RT has to be given, how long it will be given, some of the baseline investigation they should undergo before starting treatment. All the process we have to orient them. And the treatment environment, like already I said, this is the treatment environment, this is how the RT will be given. All the information we have to orient them. Then the importance of radiation tattoos. The third picture is a radiation marking. This will be done by the doctors during the planning session itself. Tell them to not to erase or scratching those markings. This is very important throughout the RT period. And some of the possible potential side effects and its management also we have to teach them before starting the treatment. The importance of a skin care, some of the GI symptoms, example, constipation, diarrhea, vomiting. These are all common side effects. Once the treatment starts, they may develop. Then the importance of monitoring and the follow-up care. Next slide, ma'am. Coming to the side effects of radiation therapy, as I said in the first slide itself, RT is a local treatment. So side effects also usually depends on the area exposure. So we have early side effects and the late side effects. Early side effects occurs during or shortly after the treatment. Maybe after a week, they may develop some of the side effects. It is a short term, mild, and it is treatable. It will subside once the treatment ends. Maybe up to a month it will be present. Some of the late side effects can take months or even years to develop. It may be prevented by accurate treatment planning and appropriate timely intervention. Slide, ma'am. These are some of the possible early side effects. Not all the children's having all of these side effects. Some may be one or two, or some may not be developed by any of the side effects. So we have to teach them. These are all possible side effects they may develop. Those are skin irritation, hair loss, fatigue, nausea and vomiting, headache, oral mucositis, myelosuppression, either diarrhea or vomiting. Next. These are some of the late side effects. These also possible side effects. Not everything will happen in the future. Those are infertility, secondary cancer, growth abnormalities, and learning difficulties, osteoporosis, and injury to the organs like liver, kidney, lungs, etc. We are not threatening the parents by telling all of these side effects, but we are educating them, informing them. This may develop in the later period also. We'll see system-wise specific side effects. Skin is the major affecting organ. For example, if you are giving radiation to the liver tumor, means we're not removing the liver from the body to outside and giving. through the skin muscle tissues only, the radiation is reaching to the specific organ. So it is a major affecting organ. Some of the side effects are radiation dermatitis, otherwise it is a radiation burns. Symptoms are uh, dryness, redness, itching, blistering, soreness, or skin peeling. The first picture is a radiation burns or skin dermatitis. Educate them to wash the irradiated area with mild soap and water and keep that area dry and clean. They should avoid scratching those area and shaving that area using adhesive bandages and putting tight clothes. Tell them to wear a soft cotton clothing, loose cotton clothing. Avoid local application of creams, lotions, or ointments on the irritated area unless it is advised by the doctors. They should avoid exposure to the sunlight, mainly that irradiated area. Somebody will ask whether they can use a sunscreen or a moisturizing lotion. If it is prescribed by the treating doctors, mean they can use that one. Next is fibrosis. Muscle fibrosis is thickening or hardness of the muscle area, mainly that irradiated area. In that case, they will have muscle stiffness, muscle pain. For that, we can refer them for physiotherapy. We can also teach them massage therapy to relieve the pain. Then the wound healing, mainly in case of any wound ulcers, when they develop, we can give a wound care. If it is infected, can give antibiotics also. Next slide, ma'am. Next, affecting organ is a GI part. This is another one commonly affecting system. If the radiation is given to the abdomen region, uh, they will have a GI symptoms. Those are mucositis. It starts with oral. So second picture is a oral mucositis. This is how they will start the infection side effects. So we have to inspect the oral cavity every day to look for any redness, dryness, or ulcers. Encourage them to take goggles, maintain them to take oral hygiene mainly using antiseptic mouthwashes like chlorhexidine mouthwash, mucobenz's mouthwash. They can use topical anesthetic agents like lidocaine gel. This is for to relieve the pain symptoms. Then using a soft toothbrushes to prevent further damage to the oral mucosa. Provide a light, bland, moist, soft diet and avoid spicy food and hard foods like chips they should avoid. In case of a severe mucositis, if the child is not taking anything orally, in that case, we have to admit the child starting IV fluids and antibiotics. Then we can also consider narcotics and TPN, like a total parental nutrition, to meet the nutritional needs of the child. Next, ma'am. Next slide, ma'am. Okay. Next, nausea, vomiting is another common side effect. So, for nausea and vomiting, we can administer antiemetics around the clock. We can provide a small frequent feeds, ensure adequate hydration. If needed, starting IV fluids also. Next, ma'am. For diarrhea and dehydration, maintain their hydration level, encouraging them to sips of fluids. If not taking, if child is not taking, starting IV fluids. Encourage about the ORS and ask them to take a low fiber diet. Then assess for any signs of dehydration according to the severity. You can correct the dehydration also. For constipation, if because of constipation, they may develop a rectal or perianal ulcer. For that, teach them fiber-rich diet. There are creams are, available. Example, zinc oxide creams, aloe vera gel for soothing effect, laxative to relieve the hard stools, six bath with potassium permanganate that soak every day. They can take 3 to 4 times a day. That six bath. Then adequate hydration will really helpful, and local application of anesthetic agents like lignocaine gel applying before they are defecating. We have to apply that gel to the anal area will relieve that anal pain. Then analgesics and anti-inflammatory creams, I said no, that lignocaine gel will relieve so much of pain. Next is a pain. Pain is a major concern. It is a non-specific and a subjective concern. Pain is a, if we have pain, Even for we also, when we have pain, we will not do any work. If it happens to the children, it's very difficult. It is a critical aspect of the overall care. It may be a physical pain or the emotional distress, as radiation therapy can cause discomfort, skin irritation, oral mucositis, etc. Assessment of the severity of the pain can be done using a standardized scale, like a flag scale, visual analog scale, numerical scale, etc. So many scales are available according to the scope in them. Next, ma'am. As we all know, pain management is a pharmacological and non-pharmacological intervention. So some of the pharmacological interventions are administering analgesics, opioids, topical anesthetic agents, then steroids, mainly to relieve the edema and swelling. In case we can use steroids. Next, ma'am. These are non-pharmacological measures. If their children is very much interested in gardening, some of their distraction technique, relaxation therapy, they can tell them to take some relaxation. Then they can also hear some musics, whatever they like. Then massage therapy will be useful. Then tell them to go for some little exercises, like mild exercises also they can do. Then they can play with other children and doing paintings and some of the craft items and all. If they will do, they'll distract the pain, so they will be the pain free. Next, ma'am. Fatigue. Next, fatigue is another common problem. We have to teach the parents about watch for their fatigue signs and symptoms. We also watch, and we have to teach the parents also to look for some of the fatigue signs, like if the child will be more sleepiness, or otherwise they will be very irritable, apathy, trouble in concentrating the activities whatever they were doing, and they will be more anxious, and if they will be fear, and in that case they will not do any of the activities, so they will avoid those activities. And for that we have to encourage them, provide them adequate sleep, encourage them to take adequate hydration, ensure a healthy diet, provide a rest period, so not keep on disturbing the child. So we have to pacing the activities. If they are interested, they can go for light exercise if it is tolerated also. So in that case, the fatigue will be minimized. Next, we'll see system-wise side effects. First, we'll see about central nervous system. If the radiation is given to the cranial or spinal cord for the head and neck cancer and all, some of the side effects are headache. For headache, analgesics will be given, corticosteroids, example dexamethasone. Some of the osmotic diuretics, in case of increased intracranial pressure, they can give osmotic diuretics. Next is cognitive impairment. This cognitive impairment, mainly if it is given to the cranial artery, some of the brain cells also getting damaged. So in the later period, so they will have a cognitive impairment. So we have to teach the parents. They will have learning difficulties. They should not compare their children with other children's, like others are not doing very well, why our children is not doing very well, and all. They should not compare. So in case of any learning difficulties, they can also we have to teach about the cognitive therapy is also available, and some of the stimulants, neurostimulants, so it will be helpful. Then next one is radiation myelopathy. It means damaging to the white matter in the spinal cord. So in that case, they will have loss of sensation and the tingling sensation. Sometimes paresthesia will be their lower limb weakness. So for that, referring them for physiotherapy, some of the supportive cares, and if it is needed, they will administer steroids also in the early stage to prevent that. Next one. Next, alopecia. Alopecia is another common side effect. Also, it is one of the psychological issue for the developing children. tell them that it is a temporary problem. We have to explain to the older children, and if it is needed, they have to shave the hair before starting the treatment itself. If they're not willing, just provide a hair cap. Explain about the artificial hair or hairs also can be used whenever they were going out. Then hairs, then we have to tell them hair starts to regrow after completing the treatment ends. Maybe after 3 to 6 months, the hair starts to regrow. Yes, ma'am. Then hematological system, blood and in the involvement of a blood and bone marrow, some of the side effects are they will have anemia, leukopenia, thrombocytopenia. For anemia, we can teach about the iron-rich diet. Also, supplements available, iron supplements. If it is very much anemic, the child is, we can admit them and transfuse the Paxil. For leukopenia, strict anti-aging must be followed. Then they should avoid going outside in the crowded areas, otherwise they will get infection. Some of the growth factors is available if they're really neutropenic. Colon stimulating factors is a growth factors to increase the neutrophils level, and admit the child. Starting IV antibiotics is helpful. Then thrombocytopenia, bleeding precautions like they should use a soft toothbrushes, and they should avoid getting injury by during playing and all. Then if it is very much platelets is, if it is very much low, we can transfuse platelets. Yes, ma'am. Next is the respiratory system. When the RT is given to the thoracic region, some of the side effects they will have pneumonitis. For the pneumonitis, we can teach about the deep breathing exercises in a playful manner, like teach the children to give the balloons to the children so that they will blow. So the deep breathing exercises will be done, and some of the medications like corticosteroids like prednisolone will be helpful to reduce that swelling level. And if the child is dyspnea, so can administer oxygen. For fibrosis, muscle fibrosis, I already explained. If it happens in the lungs, so pulmonary rehabilitation will be given. Some of the bronchodilators and supportive cares will be useful. Next is a cough, and another common side effect. For cough, they can use antitussive drugs. Then drinking warm water, taking warm water, then saline gargling will be helpful, really helpful. And the pain for pain and discomfort, administering analgesics and comfortable environmental will be useful. Yes, ma'am. Coming to the cardiovascular system, if we are given to the thoracic region, respiratory and as well as the cardiovascular system will be affected. Some of the side effects are coronary artery disease. For that, we have to teach us some of the lifestyle modification. They every day they should go for walking. Some of the exercises they can continue taking vegetables every day and avoid some of the junk foods and all. Be helpful in this disease. Then antihypertensives in case of hypertension. Then pericarditis using a non-steroidal anti-inflammatory drugs, and if for the pain and in case of severe we can they'll give steroids also. For arrhythmias, ECG monitoring and anti-arrhythmic drugs will be administered. Coming to the endocrine system, when we are giving radiation to the cranial, the master gland is present in the cranial, that is a pituitary gland. So if we given to that region, radiation given to that region, so that hormones also will get affected. In that case, they will have hypothyroidism, adrenal insufficiency, and growth hormone deficiency. For that, all that replacement will be given after identifying those problems. That interventions will be done. For hypothyroidism, levothyroxine is a replacement. For adrenal insufficiency, corticosteroids will be given. For growth hormone deficiency, growth hormone therapy is given in the children. Next. When the RT is given in the pelvic region, urinary system also gets affected. Some of the side effects are cystitis. For cystitis, tell them to take a fluid intake, adequate fluid intake, using a urinary alkalizer and antispasmodic drugs relieves those symptoms. For hematuria, bladder irrigation, hemostatic agents in case of severe. For renal damage, they should avoid nephrotoxic drugs also, and nephroprotective measures they have to follow. Not only urinary system in the pelvic region, so reproductive system also will get affected in the later period. They may develop infertility. For the infertility, they can if it is adolescent children, they can preserve their ovum and the sperm by saying a sperm banking. For ovum, oocyte retrieval measures are there. So before starting a treatment, they can preserve the either sperm or ovum. For early menopause, hormone replacement therapy is there. Erectile dysfunction, some of the medications available like a sildenafil for the erectile dysfunction. So that one they will that will be given according to the doctor's suggestion. Then counseling is very much helpful for the problem. Next one. Coming to the musculoskeletal system, that is given to the what is it, bones or the muscle region. They will have osteoporosis, fractures, muscle fibrosis, some of the side effects. For osteoporosis, the supplement with calcium and vitamin D. For fractures, some of the orthopedic interventions like surgeries, and for pain management will be helpful. Muscle fibrosis, we can also refer them for physiotherapy. Some of the stretching exercises and analgesics will be helpful to manage those side effects. Next is acute radiation syndrome, otherwise called it is a radiation sickness. It is very rare and life-threatening condition. It occurs when someone is exposed to high dose of penetrating radiation in a short time. It is this type of radiation is given after before the bone marrow transplant. There is a total body irradiation will be given. In that case, they will be they will have a severe nootropic. They will go to severe nootropic state. In that time only they will develop this syndrome. Some of the symptoms are malaise, anorexia, severe diarrhea, fever, dehydration, and electrolyte imbalance. The management of the symptoms are decontamination. Decontamination means removing the clothings that is exposed with the radiation. So removing that clothing and wash the body with the soap and water, mainly to reduce the further exposure to the radiation. Then supportive cares, like in case of diarrhea, we have to treat the diarrhea. For fever, antipyretics. For dehydration and electrolyte imbalance means electrolyte corrections has to be given. With that, we have to manage those problems. Next is monitoring and reporting. This is very important for the growing children. After completing or during the treatment, we have to monitor, assess the child's physical and as well as emotional status, monitor their growth and development and overall well-being, document and report any significant changes or adverse effects to the healthcare members. Next, ma'am. Next is long-term follow-up. Monitor for, I said many of the late side effects. Those side effects they have to monitor. Late side effects of radiation therapy such as growth delays, learning difficulties, or any secondary cancers. We collaborate with other specialists like oncologists, pediatrician, physiotherapists for the comprehensive care. Next slide, ma'am. To conclude, radiation therapy in cancer treatment can be a curative or palliative. If side effects occur, it should be addressed appropriately. Nurses should be knowledgeable and skillful in identifying, managing the side effects, and supporting the child and family. Thank you, ma'am.
Mrs. Menaga, are you concluding?
Yes. Thank Ravati for the wonderful presentation on how to manage the possible side effects of children undergoing radiation therapy. Thanks to Dr. Patricia and Ravati very much for the efforts and your wonderful presentation. Are there any questions? You can ask the speakers.
Dr. Patricia has been replying to the specific queries in the chat box, so people are getting specific answers for the question.
Okay,
So
okay,
I
okay.
think that's fine.
Okay.
So thank you very much, Mrs. Menaka. She's been coordinating all the three webinars for us, identifying speakers and coordinating with the resource team for us. Thank you very much for moderating our webinar today. Thank you.
Thank you.
We now have Dr. Priya John, our General Secretary, and we would request her to say a few words.
Thank you, Shami, and thank you, Dr. Patricia and Mrs. Revati for your presentations. Always nice to see you, Dr. Patricia. So calm and composed for your presentation. So nice that was. Yeah, thank you for dealing with these difficult topics. I think as healthcare professionals looking after children with childhood cancers, I think would be the most challenging. And I'm just hoping somewhere down after all these sessions, Mrs. Menika, if there is some support mechanism for the caregivers and the healthcare professionals, when they deal with these challenging, um, situations of giving care to the children. Is there something that, as caregivers in the family, they can protect themselves with, as well as the healthcare professionals themselves? What are some of the measures that CMC is doing, or is there some advice you can give? Because somewhere that strength is also required. But thank you. Thank you for giving us your time today and for giving us insight into so many little things. I think the nursing care is very, very crucial in any health, service delivery. And especially in cancers, just to give that extra patience, extra support, extra word of encouragement and kindness is so critical. So thank you, Mrs. Revati, for your presentation and for giving us very detailed, uh, you know, uh, uh, points for each system that is affected because of radiotherapy in children. So thank you very much for that detailed report. And thanks very much to everyone who has joined today. It's nice to see a good participation. We hope that these lectures will benefit you in your area of work. And do reach out to us when you have any questions. I think there is a question, Shimi, regarding when the content of this will be available and also certificate of participation. So if I will hand over back to you if you can answer those questions. So thank you once again, everyone. Thank you.
Thank you, Dr. Priya, for being with us today and encouraging us. For the certificates, yes, we will be displaying our email ID at the end. So you can write to us if you need a certificate, and our team will get back to you for the process, and we'll be issuing an online certificate. And the content, yes, we are trying to post all these webinars on our website. So as and when you need to refer or take notes or go back and listen and you want this webinar to be again used for your student learning purposes, you can use them. So we will soon put up these webinars, all the three webinars on our website. So you can go to our website www.cmai.org and you can find the resources there. So you can use them in the future as well. We had a lot of students joining today, almost more than 250 students are joining from different schools. So thank you, students, for the enthusiasm and for joining all the three webinars. So thank you very much. I hope we have answered your questions. So we will now thank our resource team, especially Dr. Patricia, for taking her time off. She's a very busy person and she has a big unit to take care of. And so we'd like to thank her for taking this time off today and helping us understand about the basics of radiation. Especially our students would have learned a lot from you today. And thank you very much for being with us today and sharing your expertise with us today. Thank you very much, Dr. Patricia.
Welcome, and it's my pleasure.
Thank you. We would like to thank Mrs. Menaka once again for coordinating this webinar, especially in all the three webinars. She has worked hard to make it a successful event for all the three webinars, finding appropriate resource team, So when we approached her in the beginning, we approached her in the month of November, where we wanted to do like this one, and she was very much passionate about coordinating this webinar, and we thank her on behalf of CMA and NL. Thank you very much, Mrs. Menaka, for all the help and support on behalf of CMC. We would like to thank all the nurses who have participated as resource persons, and special thanks to Revati for joining us today and sharing her all the content regarding the nursing care. Thank you, Revati, for taking the time to prepare so well for this for the part given to you today. Thank you very much. We would like to thank the Dean of the College of Nursing and the Nursing Superintendent for permitting their nurses to and the faculty to participate in the webinars and be part of the resource team. A special thanks to all the principals who have made arrangements for the students to participate in groups, and all the nursing superintendents who have made arrangements for the nurses to join in groups today. Thank you very much. Special thanks to all the senior members of the Nurses League for supporting us for all these events. Thank you very much. We appreciate your support to NL. Special thanks to all the staff of CMI and also all our IT team and all our supporting team at the behind. Thank you very much for helping us and do this webinar in a very successful manner. So thank you once again. And as we close, we'll have a closing prayer, and I'll request Shalini to do the closing prayer. Shalini, you're muted.
Let's pray. Okay. Thank you, Father, for this time. And thank you that we are together here for this fellowship. Just want to thank you for your love, for your grace, for the provisions which you provide us. Thank you for the beautiful sharing today. We know, Father, that those who are suffering with cancers, we pray that your healing hand upon them, and we pray that you heal them completely, Father. We know that nothing is impossible for you. You can move any mountain, Father, from our lives. So today we declare that every single mountain in our lives, whatever it can be, is cancelled, uprooted right now. We thank you for this time and this opportunity to be together, learn something in this fellowship, and we pray and commit each and everything into your hand for your guiding us and leading us in a right way. I commit everything into your hands. In the name of Jesus, we pray. Amen.
Thank you, Shalini. Thank you all once again. Students, thank you very much. And staff from Jagdishpur also have joined as a big group. Thank you, Mrs. Elizabeth, for making it possible for them all to attend.
Thank you, Shimi.
Thank you.
Thank you very
ma'am.
much.
Thank you.
It was a nice time of learning together. I too enjoyed, and I learned a lot by this activity. Thank you so much.
We have put the email IDs in the chat box, so you can note the email ID. The students have left. Gems is there, Bisam Katak is there, Damtari is there, GD Bagaria School of Nursing from Jharkhand. Students, do you want to give your feedback? After attending all the 3 webinars, was it useful? Are the students still there?
Hello, am I audible?
Yes, yes.
Yeah, hi. So I'm not the student. Actually, I'm working with the MNC. My name is Payal Priya. I'm a global medical coordinator in Medix Global. And somehow, like just 3-4 days before I came to know about this group and I joined. And currently, I'm working with the cancer patients across the world, and I'm exploring palliative as well. So this seminar was definitely useful for me because mostly I was engaged with elderly geriatric cases and some sort of women related cancers. So this pediatric portion was completely avoided. And when I saw this topic, so I thought, why not to join? And I learned a lot. Thank you to the speakers, and it was really useful. Thank you so much.
Yeah, you should listen to the previous 2 webinars as well. It was very good. Understanding the basics and also the chemotherapy in children.
Mhm.
So maybe you
Sure.
can, yeah, you can later check on our website and learn, get to see that also. It was all very practical aspects, and it was really good. But thanks
Sure.
for joining. That's really encouraging to see how our webinar has helped you.
Thank you. Thank you so much. And definitely I'll check on the website. Thank you so
Yeah,
much.
yeah. Thank you. And GD Vagaria School of Nursing is a Catholic school in a very remote part of Jharkhand. So thank you, Sister Kiran, for enabling the students join. They attended all the 3 webinars, and there's a big group there sitting. So thank you, students. You want to wave your hands and show who you are? Can you hear us? Yes, yes, they're waving. Yeah, yes, yes. Thanks, thanks. Thanks for joining. I hope it was useful for you. Bisum Katak and Damtari and all that. We did have some A&M schools joining. I haven't even heard those places' names. Some Sukpal and all that. Purnia, Nirmali, Sukpal and all that. I don't know. They are government A&M schools, I think. Okay, everybody, thanks for joining. We will come up with more topics, especially on cancers. When we are ready with that, we will again let you know. We will note down the email IDs. That's why we collected the email IDs. We will inform you when we are ready with the next series of webinars. We are working on it along with College of Nursing CMC Vellore, and once our series is ready, we will come back to you and we'll start the next series. Thank you for joining. Bye-bye. Good day. Thank you, Dr. Priya. Thank you for joining.
तुम्हारा शूट करता है अच्छा हाँ
Okay, we